everyone. And thank you, Dr. Barbaro, for joining us. So this session is the prenatal screening for early intervention in sickle cell. So we're going to have a video play, and then Dr. Barbaro will come back and ask, just finish up, wrap up, and any questions for 5 minutes. So we'll have the recording and then we'll have questions for this session.
My name is Pasquale Barbaro. I'm a paediatric haematologist at the Queensland Children's Hospital with an interest in managing paediatric patients with hemoglobinopathies and sickle cell disease. So today I'm going to talk about prenatal screening for early intervention in sickle cell disease. So the principles of screening for any type of disease really come from this document from the World Health Organization, which was published a while ago now in 1968, but really the principles in this document are valid even today. And the document really states that the aims of screening for a disease are to try and reduce the burden of the disease in the community and in individuals, to reduce the morbidity and mortality of the disease and improve disease outcomes. It also highlights that screening doesn't come without costs, and there are potential problems with any sort of screening program, because ideally screening involves identifying people who may have a disease but are yet symptomatic of that disease. So in essence, I'm trying to identify patients who are healthy where early intervention can help with that disease. So if you're screening a lot of healthy patients, potentially you can have false positive results, whereby the patient or the person doesn't have the disease, but the test says that they do. And that can obviously lead to quite a lot of anxiety around that potential false diagnosis in that patient. False negative results can also occur. So this is when a patient does have a disease, but the screening test says that they don't. And that would lead to a misdiagnosis and potentially the patient not having early intervention and then presenting with either complications from that disease which may have been preventable. There are some diseases where they're relatively mild, and if you screen for those diseases, there'll be an overdiagnosis of certain conditions that may not actually impact the disease. And I don't think sickle cell disease falls into that category. And obviously there are some other physical and psychological harms, physical harms being the testing itself does involve a blood test, and the psychological harms which we've spoken about. The WHO document really identifies acceptable criteria for what you should look for in diseases before going ahead and screening. And they state that disease should be an important health problem. There's no question that sickle cell disease is an important health problem. And we know that by the fact that 50% of children in parts of Africa who are born with sickle cell disease unfortunately die before the age of 5 years of age. We also know that even in Western countries where we do have a much better treatments available for sickle cell disease for things like infections and hydroxyurea to stop vaso-occlusive episodes. We know that even in Western countries or developed countries, adults with sickle cell disease still suffer quite a lot of morbidity and mortality, and their life expectancy is not as good as the general population due to chronic damage from sickle cell disease. So there's no doubt that sickle cell disease is an important health problem. The WHO also states that there should be a recognised latency or early symptomatic asymptomatic stage so that you can identify patients with diseases and institute treatments prior to developing any symptoms or complications, potentially improving patients' outcome. And we'll talk a little bit about that in sickle cell disease. Similarly, the natural history of the condition should be known so that when you identify patients, you have a good idea of what's going to happen to them and what can be done. Treatment options should be acceptable to patients with recognised disease. And again, I'll talk a little bit about treatments, but we do have acceptable treatments and effective treatments that we can use for patients with sickle cell disease. There should be agreed policy for whom to treat as patients. Well, I think everyone would agree that all patients with sickle cell disease deserve the opportunity for adequate treatment. And facilities for diagnosis and treatment should be available. So again, I think in Australia we have a number of pretty much all the paediatric centres around the country, and many adult centres now in each state have sickle cell disease units that have now amassed a good amount of knowledge about how to treat these patients. So once we identify patients with sickle cell disease, there are good units now who specialise in the management of sickle cell disease in Australia that can offer pretty much world-class treatment for these conditions. The cost of screening was identified in the WHO document and should be economically balanced. So again, at the moment, things like newborn screening, the entire population for a relatively rare condition such as sickle cell disease may not be economically viable. And that's where really prenatal testing and screening really does make much more financial sense. In saying that though, migration patterns are changing very quickly in Australia, and the prevalence of sickle cell carriers is increasing each year. So at some point, newborn screening of all newborns in Australia for sickle cell disease and other hemoglobinopathies will most likely be economically viable. So we've spoken a little bit about that. So the WHO document looks at ways to screen, and really the best way is prevention. And I think this is where prenatal diagnosis can offer a preventative strategy against sickle cell disease. And we have seen in countries like Cyprus that instituted a large-scale prenatal testing for beta thalassemia. We saw the effectiveness of that with no babies born with beta thalassemia major over a period of sort of 5 years once they had set up adequate prenatal testing for that condition. So that's what I'll be talking about today. But really, if you can't or there is limited capacity to do prenatal testing and intervention, that's where early detection comes in. And early detection can come from newborn screening of all babies with who are potentially at risk of sickle cell disease, or all babies in general. But early detection can also be testing a baby who is at risk for sickle cell disease because both of their parents are carriers. And again, we'll talk a little bit about that. Ideally, you don't want patients to present with symptoms and complications from sickle cell disease, which occasionally are fatal, such as overwhelming sepsis or a bad splenic sequestration in a baby who is unaware or the family is unaware they have sickle cell disease. Those things can be fatal. So this is what we're really trying to avoid in any screening program. So prenatal screening is really looking at identifying couples who are at risk of having a child with sickle cell disease. And ideally, this is best done prior to conception. So that requires, though, that people, both the general population, but as well as general practitioners and obstetricians, are aware of the risk of sickle cell disease. And not only are they aware, but they offer the correct test to those patients. So obviously patients who are from endemic areas where sickle cell disease is prominent, so sub-Saharan Africa, the Middle East and parts of the subcontinent, patients should be offered specific testing for their carrier status of sickle cell disease. Again, in that very early preconception stage where they're just thinking about having children. But I guess it's important to realise that patients, if you have one parent who's a carrier for sickle cell disease, then it's important to realise that the other parent may in fact be a carrier for another beta globin variant such as beta thalassemia, and they can interact and also give you a potential child with a sickling disorder. And the beta thalassemia carriers is really anywhere in the sub-equatorial regions. So Africa again, but also the Mediterranean, parts of the Middle East and many parts of Asia. There are a high rate of carriers for beta thalassemia. So again, it's important that that is recognised and the testing is done appropriately. As I said, migration patterns are changing. So over the last sort of 5 years, the increase in migration from Africa has jumped a few thousand. So potentially we're looking at somewhere between 1,000 to 1,500 carriers of sickle cell disease migrating to Australia each year. So this is a problem that will most likely get worse. But as I said as well, it's important to realise that patients with sickle cell who are sickle cell carriers can have children with people from beta thalassemia endemic countries like the Middle East or Southeast Asia and have a patient with sickle cell disease. And again, the increase in migration from those parts is not as dramatic as from sub-Saharan Africa, but it is increasing. So for couples who are at risk, I think it's important just to go over the genetics. So sickle cell is an autosomal recessive condition. So you have carriers where they have one normal chromosome with the normal beta globin gene and one chromosome that carries the sickle cell gene. So potentially there's a 1 in 4 chance they can have, this couple can pass on both the normal genes and have a normal child. But there's a 1 in 4 chance that their child might inherit both sickle cell genes and be affected with sickle cell disease. And then there's a 1 in 2 chance that they'll also be a carrier. So identifying carriers really relies on performing the correct test. So you cannot identify a carrier of sickle cell disease just by doing a full blood count, because a full blood count, especially the MCV, is almost certainly normal in most carriers with sickle cell disease, unless they also co-inherit alpha thalassemia. So you really have to do the thalassemia or the hemoglobin studies, what's also was referred to as hemoglobin electrophoresis. So that's the only test that you should be doing when you're looking at carrier status in patients who may be carriers of sickle cell disease. So there are some guidelines out there for obstetricians and general practitioners as to who to test and what tests to be done. So this is from the Royal Australian College of Obstetrics and Gynecology as part of their genetic carrier screening document. And their second recommendation is that all pregnant women should be offered a basic screen for thalassemia carrier status with a full blood count and initial presentation. Unfortunately, this doesn't highlight sickle cell disease specifically. It does just say screening with specific assays for hemoglobinopathies should be considered in high probability ethnic or population groups. And unfortunately, there's very limited, this isn't expanded anywhere in the document about which groups should be identified. And it doesn't mention sickle cell disease specifically. So again, I think there's obstetricians might read this and just think a full blood count is appropriate for picking up all hemoglobinopathies, not realizing that it will not pick up women who are carriers for sickle cell disease. They really need to do HPLC and EPG. So this document probably needs a little bit more detail. The document also says that all couples with a high chance of having a child should be offered genetic counselling, or it may be appropriate for that couple to be seen by a clinician of the relevant expertise. So again, genetic counselling, but also potentially the couple being referred to a paediatric haematologist to discuss what it's like for patients with sickle cell disease before they go on and think about their options. Similarly, the general practitioners have a little bit of a guideline, and their guideline is a little bit better in that they identify which parts of what ethnicities should be offered testing. And then they also have a part about testing, including hemoglobin electrophoresis, which will pick up the patient. So again, this is a good document for general practitioners to be doing the right thing. It also comes with a little bit of help in interpreting the tests. So when you have identified a couple that is at risk, what are the options for those couple? Well, the first option is really just to do nothing. So some couples will take that 1 in 4 chance and proceed with a normal conception and a normal pregnancy. It's really important, though, if that is the case, that the baby should be offered testing as soon as they're born. So many clinicians, unfortunately, think that a baby cannot be tested at birth for these conditions because they don't present till 6-12 months of age, but that's incorrect. So at birth, normal babies will have the fetal hemoglobin, which is the baby hemoglobin, but they should also have relatively good amount, about 20% of normal adult hemoglobin. So when you test them, you can pick up adult hemoglobin and fetal hemoglobin. Whereas babies with sickle cell disease, they can't make the adult hemoglobin. So at birth, they have, again, normal fetal hemoglobin, but they should have about 20% adult hemoglobin. So you can see that they have no adult hemoglobin and all sickle hemoglobin. So you can identify babies who have sickle cell disease if you do the correct test, which is the hemoglobin studies. And why we want to identify these patients early is because we can institute treatment right from birth to reduce their mortality. So this was a randomized study back in the 80s, which randomized penicillin prophylaxis to placebo and showed a marked reduction in invasive pneumococcal infections. And additionally, additional vaccinations also provide benefit from invasive pneumococcal vaccinations. Thankfully, in Australia, all newborn babies receive some pneumococcal and meningococcal vaccinations. However, when a baby is identified as having sickle cell disease, they will then receive additional vaccinations against meningococcal B and pneumococcus, both in the first year of life and then a booster with pneumococcus at 4 years of age. So it's also important to identify these patients early because hydroxyurea does reduce complications like vaso-occlusive episodes, hospitalizations, transfusions in children with sickle cell disease. So again, identifying that there's an at-risk couple, doing the right test on the baby when they're born leads to early institution of treatment, which can improve their outcome. And we know things like newborn screening do have a big impact on patients' lives. I'm just going to skip over that because the next person will talk about newborn screening. So I guess that there are other options for at-risk couples. So they can conceive naturally and have an early test on the baby with the so that they know if the baby's affected or not, and then that gives them the option for selective termination. So the testing, though, involves a CVS or amniocentesis, and there is a risk of miscarriage with that test, unfortunately. There are newer non-invasive techniques coming by, but I don't think they're widely available in Australia yet for sickle cell disease. And again, this is time critical because if you are going to do a selective termination, you really need to identify that there's a baby who's affected within 12 weeks so that termination can be done prior to 20 weeks. So again, identifying couples early who are at risk, testing early gives you the best option. I guess the couples also could have the option of doing in vitro fertilization and pre-implantation genetic testing. So this is only possible, though, if you identify those couples pre-conception, so before they are pregnant. Unfortunately, this is quite a costly exercise. So you need the cost of the actual in vitro fertilization itself, which is anywhere between $5,000 and $10,000. This doesn't cover the cost of hospital stays, which are often needed for these techniques. And then the cost of the actual pre-implantation genetic testing is probably about $2,500 for one IVF cycle. So you can see that this costs anywhere between $10,000 and $20,000 per pregnancy. And again, these are not Medicare rebatable tests. So this is going to be out of pocket for patients. And a lot of that, unfortunately, is not, well, many patients can't afford this. But ideally, it would be good if this was all Medicare rebatable, because, you know, the long-term cost to the public health system for patients with sickle cell disease could be completely avoided by the government spending this $20,000 up front, which would save them, you know, magnitudes more, ideally. So look, testing of sickle cell disease, it's definitely an important problem. There's latency period. We know the natural history. Treatments of patients are recognised. The tests should be acceptable, which it is, and policies for who to treat are there. And we do have good facilities for treating these patients. But ideally, I think prenatal screening of at-risk couples does offer many more options to those couples. And the option of potentially preventing that couple having a baby with sickle cell disease is a huge advantage of testing of couples, prenatal testing. Thank you.
Great. Thank you, Dr. Pasquale, for that information on the importance of prenatal screening and also what options are available for couples at risk. I just quickly have some questions. I'll ask this one, though you already answered it, but just for those who come and hear this session later. So it's till which week can amniocentesis, if that's correct, till which week can amniocentesis be done for genetic testing? I think there's something wrong with your sound. We can't hear.
There we go. Can you hear me now? That's
yes, yes.
So as I said, ideally, if you're going to do amniocentesis for the purpose of selective termination of an affected fetus, it should be done somewhere between sort of 12 and 18 weeks, so that you can have that termination, you know, before the 20-week mark. So depending on the obstetrician, some will do it from 12 weeks, some will do it only from 15 weeks. But really, the earlier, the better. So if you can get it done anywhere between that 12 and 15-week mark, that gives time for the testing to be done, which can take a little bit of time, a few weeks to get the results back, and then you can have the option of selective termination. But again, I think testing amniocentesis really should only be done if the couple is going to, you know, act on that information. I think so. It really depends on why you're testing, why the couple's being tested.
Great, thanks. There are no more questions that I can see in the chat, so I will ask one. So I think you've talked about like having the knowledge prior to conception will help with that decision making. What do you think is needed in terms of like mindset changes from like, you know, people who are at risk and the health professionals as well, to increase the number of people that can come in for early detection?
Yeah, I mean, I think it's probably a combination of community awareness and awareness from probably primary carers. So in this case, general practitioners. So, I think it's up to communities of, at-risk populations to, openly discuss sickle cell disease, openly talk about getting tested before having children, so that you know the risks and you have the options if you would like to, to take up any of those options. So I think it's around educating at-risk communities about the disease and also about the testing and options available. But also, as I said, it's probably most of the sort of preconception, pre-pregnancy planning is done through general practitioners. So again, it's about educating general practitioners a little bit more. And as I said, the document for general pediatrics is very good. It gives quite clear instructions about who should be offered testing for sickle cell disease. But again, I think that probably needs to be reiterated through general practice training and afterwards, so that the general practitioners know who to offer that testing to and when to offer it. So it's sort of a combination of community education as well as education of primary physicians or primary carers, GPs.
Great. I think this one, Isabella, Dr. Pasquale has answered this. Some couples are often not always aware they're carriers. What options do they have?
Well, that's tricky. If they're not aware they're carriers, then, they probably won't test the baby. They won't do anything. So, as I said, I think the important thing is to educate communities who are potentially at risk. So, people who are from sub-Saharan Africa, India, and Middle East, the communities should have open discussions about sickle cell disease and really encourage people to be tested for their carrier status prior to marriage and having children. If you don't know you're a carrier and you've never had a test and you get pregnant, unfortunately, if no one's raised that issue then with you, then you've kind of missed the opportunity for testing. But again, if you do get pregnant and you're from one of these at-risk populations, again, at booking, so at the 12-week booking mark where you see either your GP or your obstetrician, that's another opportunity for testing. And so if you can do that testing at a booking, at least you have the option of amniocentesis or CVS to test the baby and see if they are affected or not, to then have the option of selective termination or not. So I think if you don't know your carrier status and you do get pregnant, again, it really is up to the obstetricians and the general practitioners when they see a pregnant woman early in their pregnancy who is at risk to do the proper test and then refer appropriately so that couple can talk about their options.
Great. Thank you. Thank you, Dr. Pasquale, for your information. We've come to the end of the session. Thank you for your time. And the next session on the importance of newborn screening, so a continuation, is starting now. So there's some links in the chat for those who want to go to the next session. Okay. But thank you very much for your information, Dr. Pasquale, and your time.